Afternoon, everyone. Welcome to the Yale Sleep Medicine Grand Rounds. My name is Ritika Thapa. I'm one of the pulmonary critical care and sleep medicine faculties here at Yale. Just some brief announcements before I introduce our today's speaker. Please ensure that you are muted. In order to receive the CME credit, please see the chat room for instructions, and the instructions do come periodically. You need to sign up to get this credit, and if you have not signed up already, please send a message to Debbie Lovejoy, and if you think anyone else is interested in joining, please reach out to her as well. If you have any questions or comments during the presentation, please use the chat room, and you can also unmute yourself at the end and ask the questions yourself, and I will also moderate the session. Recorded versions of these lectures will be available on YouTube a few weeks after the presentation. And now I have the extreme pleasure and honor of introducing Dr. Babak Mokhlesi today, who probably does not need any introduction. But Dr. Mokhlesi received his medical degree from University of Monterrey School of Medicine, Monterrey, Mexico. He then completed his internal medicine residency at Weiss Memorial Hospital, University of Chicago, where he was also a chief resident, and his pulmonary critical care and sleep medicine fellowship at Northwestern University, Chicago. He's currently the J. Bailey Carter Professor of Medicine at Rush University Medical Center, where he is also the Chief of the Division of Pulmonary Critical Care and Sleep Medicine, as well as a co-director of the Rush Lung Center. His research has primarily focused on obesity hypoventilation syndrome, non-invasive ventilation, and the intersection of sleep and metabolic disease, exploring the impact of OSA, hypoxia, and hypercapnia during sleep and wakefulness on cardiometabolic outcomes as well. His translational research program is looking to better understand the downstream effects of obstructive sleep apnea, that is hypoxemia, hypercapnia, and other comorbidities. He has led landmark multi-center studies on the management of OHS. The Pickwick Papers played a central role in the ONMAC expert panel that recently also redefined the national policy on non-invasive ventilation in COPD and has contributed to NIH-funded research like RISE today that has advanced our understanding of sleep-disordered breathing. He has also lectured nationally and internationally on these topics. He's received many awards, is a recipient of several NIH grants, and has authored over 190 peer-reviewed publications. It was really difficult to go through your CV, including in the NEJM, American Journal of Respiratory and Critical Care Medicine, just Dr. Mokhlesi has also had leadership positions in many national societies, served on the editorial boards of leading journals, and is currently the deputy editor-in-chief of Journal of Sleep, Clinical Sleep Medicine. He is also widely recognized for his commitment to mentorship and faculty development. Thank you so much again for being with us, Dr. Mokhlesi. And without further delay, I would like to hand it over to you to share your expertise on obesity hypoventilation syndrome, lessons learned from the Pickwick Papers.
And thank you so much for the kind invitation and introduction. It's great to be with you. So without further ado, let's just get started. I was tasked to talk about OHS, which is, as you mentioned, is an area that I've been very interested in clinically and research-wise. Here, let's see if I can advance the slides. There you go. For the CME, I guess. There's a code. And here are the learning objectives that I shared with you earlier. So I won't talk about them too much. We'll just dive into it. So let me start with a little bit of a historical perspective. I always like to point out that obesity hypoventilation syndrome was actually described before obstructive sleep apnea. In the mid-50s, it was initially described. And as you can see on some of the citations here, what was interesting is that before the publication that really coined the Pickwick term, there was one president that actually referred to it, and this was Howard Taft. He mentioned in the early 1900s when he was president that he had lost a tendency to sleepiness, which made him think of the fat boy in Pickwick, the Charles Dickens Pickwick Papers. So one could argue that he's the first one who coined the term for Pickwickian. And this is an interesting article that I encourage you to read, where it was published in Chess more than 20 years ago, looking at Howard Taft's career. The arrow here is when he became president. Before that, he was Secretary of War. I guess our Secretary of Defense may change to Secretary of War again, given the ongoing political climate. But so before he became president, he made the observation that he's going to make to his wife that he's going to make conscientious effort to lose weight. He called it flesh. So because he was worried that if he gets appointed to the bench, to the Supreme Court, he won't be able to function well, because that was his dream job. But again, he became president. He was a one-term president. During presidency, he gained a lot of weight. And when he did not get reelected, you can see he made a conscientious effort to lose weight. This is before, Mounjaro and Ozempic and bariatric surgery. So he just had aggressive dieting. And eventually he was served as Chief Justice for the last 10 years of his career. And with a significant weight loss and BMIs that went from 45, 46 to 34, he functioned really, really well without falling asleep all the time. So I don't know if he had OHS. He certainly had OSA, but I think if I would venture out and say he probably had OHS as well. So, the definition of OHS, of course, obesity is part of the definition. Although in the United States, we don't see, in people of European ancestry, we usually don't see OHS with BMIs in the mid to low 30s. It usually has to be in the 40s and higher. In Asian populations, you can see OHS at lower BMIs compared to people of European ancestry or, Black Americans, for example. Of course, chronic hypoventilation has to be present, usually defined by daytime hypercapnia during wakefulness. And most of these, if not all of them, have some sort of sleep disorder breathing, majority having severe OSA. But there's a portion of patients that don't have severe OSA or have no OSA. And of course, there's a diagnosis of exclusion as listed here. And here's a typical example of how OHS looks like. If you look at the oxygen saturation here, the sawtooth pattern is very classic for OSA, but the degree of hypoxemia, and I'll put some lines for you there, the degree of hypoxemia is above and beyond your garden variety severe OSA. Of course, the hypoxemia is more profound in REM, and you can see that on transcutaneous CO2 monitoring, also during REM, there's a little bump. But again, these patients are quite hypoxemic and quite hypercapnic. And here's an example of a 2-minute window on polysomnography for a patient. This was one of our research subjects years ago. You can see they have repetitive apneas with significant hypoxemia. And sometimes, with a few breaths that they take in between apneas, they're able to recover, sometimes not even full recovery of oxygenation, to just desat again. So you can see this level of hypoxemia is pretty profound. What I want to call your attention to, which I find very interesting, is in this study, we were doing blood pressure monitoring beat by beat using non-invasive plethysmography technique. And you can see that the degree of hypertension that they experience is quite profound. With these events, you can see the blood pressure goes from like 100 over 50s to 160s over 80s or 190s over 110. So this is profound hypertension that only lasts a few seconds. These are beat by beat measurements. So ambulatory blood pressure monitoring has difficulty capturing this because measuring the blood pressure every half an hour may not capture this, but beat to beat is quite profound, the degree of hypertension that they experience, these patients. In terms of its prevalence, it's probably more prevalent than you think. We think it's more prevalent in the United States, not because there's something wrong with us, but it's just because we have more obesity. And if you look at this graph here, these are 4 countries in different colors. And as a prevalence of obesity, if you look at the categories of BMI, like above 40, compared to lower categories of BMI, the prevalence goes up regardless of which country you look at. So it's the more obese the patient population, the higher chance that there will be higher chance of finding OHS. Years ago, I kind of did a back of the envelope calculations, and I wrote this in one of my review articles, and I've noticed a lot of people refer to it, but it's just kind of made up to some extent, although not entirely. But if you take the US population, and then you look at adults in US population, and you look at the data published by the CDC on what percentage of adults in the United States have a BMI above 40 or class 3 obesity, you get to 24 million people. And if you argue that half of these patients have OSA, and that's a conservative estimate, half of people with BMI above 40, and I'm talking about AHI above 5, that gets you to 12 million. And we had published in the past, looking at prevalence from a variety of countries, that the prevalence of OHS in patients coming to the sleep labs who have OSA is anywhere between 10 to 20-something%. Of course, there's a lot of referral and selection bias. But what I did is I took the lower estimate, 10%, and that's where I came up with this 1.2 million people who may be affected by OHS in the United States, or is 1 out of 215 adults. And here's just give you some perspective of how that compares to other conditions, in terms of narcolepsy or IPF or type 1, pulmonary arterial hypertension. So it's more common in all of these conditions listed above. Now, one of my former fellows, who's now a colleague, Julie Borak, did a nice review that's going to get published soon, hopefully, where she summarized the clinical features of these patients from a large cohort. These are ambulatory patients, more than 1,000 patients. And you can see the typical age of diagnosis is in the sixth decade of life. And this is one of the conditions that prevalence of the male-female predominance in OSA kind of goes away. In fact, in many cohorts, it's more prevalent in women compared to men. And you can see that in steady state, the average PCO2 is in the low 50s. The serum bicarb can be elevated, and the AHI tends to be high. And the majority of these patients are complain of hypersomnia. Now, when should you suspect OHS? As I said, the more obese the patients, the higher chance there is. So when the BMI goes above 40 in patients of European ancestry, Latinos, or African Americans, I think you have to start thinking about it. In patients of Asian ancestry, like China, Japan, Korea, when you look at their studies of OHS, their BMIs tend to be significantly lower than the studies from Australia, United States, Europe, and whatnot. I think the bicarbonate level, serum bicarb, can help, and we'll talk about that in the next couple of slides. Hypoxemia, when you have a patient in clinic and they have hypoxemia on pulse oximetry, and you don't have any obvious reasons for it, you cannot blame it on obstructive sleep apnea because they're fully awake. So if somebody is mildly hypoxemic, you should raise some red flags that maybe they need testing with arterial blood gas. And again, transcutaneous CO2 and end-tidal CO2 is not readily available in all the labs, but it's certainly helpful. So for the clinical practice guidelines that was published by the American Thoracic Society, we tried to summarize the literature. And this is a little busy slide, but I'll summarize it for you by saying that the data suggested that a cutoff of 27 milliequivalents or millimoles per liter of the bicarbonate level seems to be a good threshold. And is a more sensitive test. In other words, if your bicarb level is below 27, it helps you rule out or reduces the risk of having OHS. But if it's above 27, the rate of false positive is higher, and ideally you want a confirmatory arterial blood gas. So this could be something that could be used in clinic and say, you're thinking, okay, I have this patient with a BMI of 49 or 50, and I'm going to order an in-lab polysomnogram, and you have limited number of transcutaneous CO2 monitors. Should you order it with transcutaneous CO2? And if you have a recent serum bicarbonate that is below 27, one could argue that even if they have hypercapnia, it's going to be a mild form of hypercapnia, and it may not be worth doing transcutaneous CO2 monitoring, especially if that's a limited resource you have. With that said, I think there's caveats to this. Be mindful that elevated serum bicarbonate levels can be seen with medications like loop diuretics or sometimes other diuretics. But low serum bicarbonate is also important to think about. I always tell my fellows, when you interpret the bicarb, look at the BUN and creatinine, because if the patient has CKD, then the ability to retain bicarb can get compromised. So the patient could have hypercapnia, but the bicarb is normal. And right now, we don't know how to work in terms of these medications for weight loss, like GLP-1s or the SGLT2 inhibitors, which many patients get prescribed for cardiometabolic disorders. The reason I bring it up is because if you're on, for example, Zepbound, which is tirzepatide, and you're eating substantially less in terms of caloric intake, and you could develop some degree of starvation ketosis, and that could consume your bicarb. So how bicarb is going to hold up in these scenarios is not well understood right now. And I think that's going to be an area that requires investigation. So I'm going to share with you this case briefly. This is a patient that is undergoing transcutaneous CO2 monitoring. This is the TCM here, and you can see is around 48. And they're undergoing titration. This is CPAP of 8. And this is just about the time that they're falling asleep at the beginning of the night. This is the part of the study. And here I want to call your attention to the first REM cycle, the person at early REM. You can see the CO2 is 71 now, the transcutaneous CO2. But the flows look pretty normal in this REM. Oxygen saturation looks reasonable. And then, of course, the tech is getting nervous here. And here's a second REM. Now the transcutaneous CO2 is 100 millimeters of mercury. Of course, quite abnormal. But the flows look reasonable, and the tech switch from CPAP to bi-level, and you can see the patient is getting probably around 20/12 IPAP and EPAP, yet the hypercapnia is still there. So this created a lot of headaches for the tech, of course, and the tech was getting nervous and calling one of our colleagues in the middle of the night to find out like what to do. But I think it's important to understand the limitations of our technology. And I hate to do this to you, but I'll take you back a little foray towards medical school and alveolar gas equation. So here I'm showing you how we calculate how much oxygen gets into the alveoli. If you take the barometric pressure minus water vapor pressure times the FiO2, which room air is 21%, and you divide your CO2 by the respiratory quotient, you get the amount of oxygen that is delivered into your alveoli that can get exchanged with your capillaries, right? Through your capillaries. So if you plot the formula, your PaO2 would be around 100 millimeters of mercury. Now, if we assume that the transcutaneous CO2 that this person had during sleep study was accurate and it was equivalent to the arterial CO2, meaning 100 millimeters of mercury, and you plot it into the formula, that means the amount of oxygen that's getting to the alveoli is 25. So the mechanism of hypoxemia here is essentially hypoventilation. But if you plot so if your alveolar oxygen is 25, the highest you can get into your capillary, into the red blood cells, is going to be 25 or a smidge lower. So if you put 25 millimeters of mercury partial pressure of oxygen, it gives you a saturation of a little bit below 40%. So it begs the question, how can somebody have a transcutaneous CO2 of 100 and an oxygen saturation of 96? Based on what I showed you. So the simple answer is not possible. And this was an error. And the tech, of course, didn't know that. And a lot of steps were taken to overcome this, but this was just a faulty sensor. So and I want to point this out to you that physiologically, the scenario that I'm showing you is simply impossible. This is not a possible scenario. You cannot have a CO2 of 100 and an oxygen saturation of 96 while breathing room air, even if you're on CPAP or BiPAP. It's just not possible. So this was an error. So it's important to understand the limitations of your technology if you're going to engage in using these devices. Now, the normal carbon dioxide homeostasis, if you think about it, is, and this is a nice trivia, we have 120 liters of CO2 in our body. Now, that sounds like a lot, but in weight-wise, it's only 240 grams of CO2, and it's present in all tissues and fluids. And to measure how much we have in our blood in millimeters of mercury, you have to look at the ratio of CO2 production over CO2 elimination. And the CO2 elimination has a component of respiratory rate out of volume, which is your minute ventilation. And there's also an important component from dead space ventilation. So ultimately, if you think about it, your CO2 can go up by several mechanisms. One is increased CO2 production, but normally that doesn't happen because as CO2 production goes up, your CO2 elimination goes up hand in hand to maintain homeostasis. The more common reason is when minute ventilation goes down, or when dead space ventilation goes up. Those are the mechanisms by which people develop hypercapnia, which is synonymous with hypoventilation. So pathophysiologically speaking, in obesity, there is increased CO2 production because the fat tissue is metabolically active, and the more tissue you have, the more oxygen you consume, and in that cellular metabolism, you produce CO2. So the CO2 production goes up, no question about it, as we accumulate more mass. But why we develop hypercapnia is not fully understood. We think it's a combination of these things. The concept of leptin resistance. There is this increased mechanical load on the chest wall. There is increased dead space because of basilar atelectasis with the abdominal contents pushing up the diaphragm. Of course, there's obstructive sleep apnea leading to acute episodes of hypercapnia during sleep. That can lead to minor retention of serum bicarb in sleep, not a full compensation, but minor accumulation of bicarb. And if you don't get rid of the bicarb the next day, in an appropriate manner, you can see how you might start the day with a little bit of alkalemia, and that could blunt the ventilatory response. And that, we think, ultimately can lead to chronic hypercapnia. And this concept of leptin resistance was really nicely demonstrated in an animal model by Seva Polatsky when he was at Hopkins. Essentially, they demonstrated that if you take diet-induced obesity mice, these mice did start developing hypoventilation, and then when they were injecting them with leptin in the peritoneum, they were not achieving any improvements. But when they started delivering leptin intranasally so that it crosses the blood-brain barrier through the cribriform structures, they demonstrated that ventilation got better in these animals, suggesting that this concept of leptin resistance could be real. Because patients with obesity, the fat tissue produces leptin, and leptin at the hypothalamic level is a ventilatory stimulant. So it begs the question, why, if these patients with OHS have such high levels of leptin, how come they're not maintaining and compensating by doing augmented ventilation? And that's where the idea of leptin resistance came about. So could there be a potential therapeutic avenue down the road where leptin is delivered intranasally for treatment? Well, we have long ways to get there, but it's an interesting concept at least. And again, why these patients develop acute respiratory failure or acute on chronic respiratory failure is ultimately this notion of load versus strength and drive. Of course, they have a lot of load, as I highlighted here, and something that increases their CO2 production, a little bit of a viral infection, or a little bit of heart failure. You can see how easily they can tip over and develop acute on chronic exacerbation and get hospitalized, which is unfortunately not an uncommon way of seeing these patients in clinical presentation. Very commonly, they present through the emergency department with acute on chronic exacerbation, and not infrequently they get labeled as heart failure exacerbation or COPD exacerbation. And then later at some point, sleep specialists or pulmonologists get involved and label the patient accurately as OHS as opposed to COPD. Now, in this slide, I'm trying to convince you that this is underdiagnosed. Granted, some of these studies are old that I'm quoting here, but this is a study from Spain where they looked at 173 patients with OHS that were admitted to the intensive care unit. Interestingly, 65% of them had prior ICU admissions, but only 9% of them were on home non-invasive ventilation. This is another study from the group in Denver almost 2 decades ago, where they looked at patients admitted to general medicine wards, and then they were screening them for hypercapnia. And then the research team notified the clinical team, by the way, heads up, we think your patient has OHS because they're hypercapnic and we have no other reason for their hypercapnia. But only 13% of them were discharged on some form of therapy. And of course, these patients had worse outcomes, those who didn't get discharged on therapy. And what I want to call your attention to is the gender differences. When you look at hospitalized cohorts, and this is a cohort from Spain, but other hospitalized cohorts of OHS have found the same thing. It's predominantly seen in women, and they tend to be much older. So when you have a patient with OHS in the hospital, it's very common for them to be an older woman. So just keep that in mind. Now, why do we care about this? Because ultimately, The point is to treat them to reduce mortality, healthcare resource utilization, improve quality of life, reduce the burden of pulmonary hypertension and whatnot. So we don't have hardcore data on outcomes. We can just make some inferences from studies, which I tried to do in this slide. So here are several studies of hospitalized patients with the years of follow-up, as you can see here. And, I'm pointing here how many of them were discharged on NIV. And you can see that at least there's some relationship here that those who got more NIV had a little bit better outcomes. Now, when you look at ambulatory patients, where patients had good adherence to PAP therapy, be it CPAP or NIV, with even longer periods of follow-up, the outcome tends to be better. But again, we don't have head-to-head comparisons in this case of no therapy versus therapy in clinical trials. Now, treatment-wise, there are a variety of things we can do. Of course, weight management is key. And now with all the pharmacotherapy options we have, I think it is an interesting area to explore. As you know, this work has been done only in obstructive sleep apnea, not with OHS. PAP therapy is important to resolve upper airway obstruction and, if needed, enhance ventilation, particularly because it gets worse at night when they sleep. I always put a word of caution about tracheostomy, because if you have a patient who's hospitalized, who is an older woman, who has milder forms of sleep apnea, and you insert a trach, you may not solve the problem, and they may still need nocturnal ventilation through the trach, because a tracheostomy can solve OSA. But if the reason behind their hypoventilation is not driven just by OSA, tracheostomy may not achieve much. In terms of ventilatory stimulants, this is an area that's, I think, actively being researched. Medroxyprogesterone is very old data from the 70s. I don't think anybody's doing it nowadays, but this idea of acetazolamide with an upper airway dilator like atomoxetine, or oral orexin receptor 2 agonists, these are areas that need to be studied. Oxygen by itself, I always discourage people to prescribe oxygen as a single therapy. It should be, if they need oxygen, it should be oxygen added to PAP therapy during sleep. And then for PAP therapy, here's your usual soup, alphabet soup, of CPAP, and then your non-invasive ventilation and your home mechanical ventilators. So short-term wise, our colleagues in Australia have done a couple of studies looking at 2-3 months of outcome, comparing CPAP with either bilevel with or without a backup rate. And in these two studies showed that there wasn't that much difference. Now, in these two studies, they excluded people who, during CPAP titration, they had persistent hypoxemia, which they labeled as CPAP titration failure. Now, this study that I'm showing you from Patty Murphy's group in the UK, they looked at 3 months outcome comparing very aggressive bilevel titration with a backup rate to volume-targeted pressure support in the form of AVAPs. And you can see that when they did an aggressive bilevel titration with BiPAP of 23/10, essentially a pressure support of 13 centimeters of water, there was no significant difference between AVAPs and bilevel ST, mostly because the delivered pressures were very similar. And then the degree of improvement in CO2 was similar, of course, and adherence was similar. Similar study was done by the French group led by Maxime Patou. And they looked at AVAPs with auto EPAP feature compared to bilevel ST. Again, when the titration is done aggressively with decent amount of pressure support, and it's not that different from AVAPs AE, the outcomes are not that different either in terms of improvement in PCO2 or adherence. Now, this brings us to the Pickwick paper. I had the fortune of collaborating with Juan Fernando Massa from the Spanish Sleep Network. This was the overall design of the Pickwick study, where patients with OHS were categorized into those who have severe OSA. And if you do the math, that's 70%. That's where the data comes from. 70% of people with OHS have severe OSA, AHI above 30, and those who didn't have severe OSA. And what I'll show you is the outcome comparing CPAP with NIV now. So this was a paper published a few years ago in Lancet. So these are, again, important thing is to reiterate, these are ambulatory patients who have concomitant severe OSA with OHS. So with a median follow-up of 5 years, you can see the CPAP pressure on average was 10-11 with a median use of 6 hours. The NIV in volume-targeted pressure support mode was on average 20/8 delivered pressures with a backup rate of 14 on average, with a median usage of 6 hours per night. So there was no difference in adherence between these two groups. There was no difference in hospital resource utilization, incident cardiovascular events, or mortality. And here's the Kaplan-Meier survival curve showing no difference. Now, when you look at those who were adherent versus those who were not adherent, so if you were in the adherent group defined as more than 4 hours, a typical definition, there was no difference between NIV and CPAP. Of course, those who were less adherent had worse outcomes, as you can see, but it was equally bad between CPAP and NIV. And most of the mortality was related to cardiovascular events, which is important to think about. Now, here's a progression of CO2 in the blood, arterial blood. You can see they both improved significantly, but there was no intergroup difference between them. And your oxygen levels improve significantly in both groups, but no intergroup difference. Now, as your oxygenation gets better, of course, many of these patients can come off daytime supplemental oxygen, which is, I think, an important issue for patients. So they don't have to walk around with oxygen concentrators or oxygen tanks. So that's an important, patient-related outcome from their perspective. And you can see that at baseline, the CPAP group, 27% went down to 13% requiring oxygen. Same in NIV group, and there was no difference between. So there was a significant drop, but no difference between CPAP and NIV. Dyspnea, which is another important patient-related outcome, significantly improved in both groups, but no intergroup difference. And here's Epworth Sleepiness Scale, on average around 11 or so, and it dropped to like 5, 6. So a significant drop in both groups, but no difference between CPAP and NIV. Now, later we started looking at gender differences. This was done by one of my former fellows, Nathan, who just joined UPenn. And he looked at men and women in the Pickwick cohort. And you can see that, again, women are on average 10, 11 years older, a little bit more obese. But what I want to call your attention to is the apnea-hypopnea index. So in men, it's quite high, as you can see. And here's your interquartile or 25th, 75th percentile. But in women, it's almost half. In fact, 25% of women almost have mild OSA if you look at the quartile of 17.9. The point here is you can see how more women are older and can get admitted to the hospital. And in the hospital, they may have milder forms of OSA. And even in ambulatory setting, they may have milder forms of OSA. Which brings us to the point, when should NIV be considered? Because all the slides I showed you showed that CPAP and NIV were the same. But I think there's an important role for NIV. Of course, in a decompensated situation, NIV is the main way to go. If there's no documented OSA or milder forms of OSA, that means mostly in women, NIV is the way to go. If CPAP fails, for example, meaning you give them CPAP, but they remain symptomatic or they cannot tolerate it, or they remain hypercapnic despite adequate adherence, you may want to consider NIV. And then, of course, this notion of persistent hypoxemia during CPAP titration, what to do with that. I always like to point out to people that in the Pickwick trial, if you were randomized to CPAP and you had a bad night doing CPAP titration, essentially you got CPAP because you were randomized to CPAP. This idea that CPAP titration didn't go well because the patient had significant hypoxemia didn't exist. And at the end of the day, there was no difference between CPAP and NIV. With that said, I know in many labs, including our own lab, when CPAP titration is not going well, after resolution of apneas and hypopneas with CPAP, and there's this persistent hypoxemia, in many labs, patients get switched to NIV. And again, I don't think that's unreasonable, but again, you can see that these are the reasons why a lot of patients may end up going on NIV for one reason or another. Now, here's some of the data that we try to analyze for the clinical practice guidelines in terms of patients who get admitted to the hospital with acute and chronic hypercapnic respiratory failure. You can see that those who were discharged without PAP therapy, and on average, 91% of the PAP therapies were NIV, had substantially worse outcomes at 3 months. 16.8 passed away versus 2.3. Now, again, the recommendations we made is that this is a conditional recommendation, very low level of certainty, because these are not data from clinical trials. These are just observational data, and there's a lot of potential for bias here. Nonetheless, is an interesting finding. Later, Nathan also looked at this cohort. You can see also predominantly women, older cohort of these hospitalized patients, older, more obese, and you can see higher PCO2s compared to the men on admission. Yet less percentage of women got prescribed PAP therapy compared to men, and they had worse outcomes. In fact, when you look at them, if you look at the subgroup of women who got discharged without PAP therapy, mortalities were substantially higher at 3 months, 6 months, 9 and 12 months. Men who got discharged on no PAP, again, the sample size is only 24 here, but you don't see a clear signal. But in women, at least, there was a clear signal. So I think there's some degree of gender bias here. You know, of course, these patients are older, so one could argue, well, they have a higher mortality rate because on average they're 10, 11 years older. But I think it's a little bit more complicated than that. So you may ask, well, I mean, now I have a patient in the hospital with acute on chronic hypercapnic respiratory failure. They survive hospitalization. Now it's time for discharge. And the guidelines suggest I should discharge them on NIV. What setting should I pick? And we don't know. But here's a little bit of data that you can use in terms of inference of what to pick. These are ambulatory patients, and whether patients were randomized to NIV or AVAPS or BiPAP ST, you can see that on average, the IPAP delivered was in the 19 to 20 range, with an EPAP of 8 to 10, with a backup rate of around 15, 14, 17, right? So if you pick volume targeted pressure support, we recommend 8 to 10 of predicted body weight. So these could be empiric settings that you can pick while your patient is waiting, for example, to be seen in the sleep clinic or undergo formal diagnostic testing after hospital discharge. In terms of pulmonary hypertension, this is an area that I've been interested in. When we looked at the Pickwick trial, upon enrollment of patients, 10% were aware that they had pulmonary hypertension, meaning they're either the patient or their providers knew that the patients had pulmonary hypertension. However, systematically doing echocardiography, understanding with all the limitations that echo has for diagnosing pulmonary hypertension, half of the population in the Pickwick trial had pulmonary artery systolic or right ventricular systolic pressure above 40, which has been associated with worse outcomes. When you look at what happens to these individuals, these are all patients, those on CPAP, those on NIV at baseline. The prevalence of pulmonary hypertension by echo drops almost by half in first year and stays there. Yet, one could say, well, that's great, but I would argue that still 28% of patients remain with some evidence of pulmonary hypertension despite getting therapy. In the subgroup of people who had evidence of pulmonary hypertension at baseline, this is the y-axis, the millimeters of mercury from the echo, the RVSP or right ventricular systolic pressure. You can see that the degree of improvement is quite significant, 8 to 10 millimeters of mercury drop in systolic pulmonary artery pressure. Of course, if your pulmonary artery pressure was normal, there's not that much room for improvement because, you know, there's kind of a floor effect, if you will. Now, I want to kind of share with you a few next few slides about weight loss. So this was the first case of weight loss documented in the medical literature. Let's forget about President Taft. So this one is a 51 case. This is a case that was described in the literature as the first case of Pickwickian. And in this paper, they coined the term Pickwickian. So this was a 51, it's a very interesting article to read. It's very fun to read. 51-year-old man who's a business executive in the Boston area, who has progressive dyspnea and exertion, lower extremity edema, severe EDS, has experienced weight gain over the last few years with a BMI of 44. I calculated BMI. I think BMI was not a common thing in the 50s and 60s, but they give you the height and the weight so you can calculate it. Evidence of secondary erythrocytosis with a high hematocrit. And this is the complaint that they put in the paper. The patient was accustomed to playing poker once a week with his buddies. And on this crucial occasion, he was dealt a hand of full house. Because he had dropped off to sleep, he failed to take advantage of this opportunity. And that by itself was enough of a trigger for him to get admitted to well, I guess what's now called Brigham and Women's Hospital. Now, I'm not a poker aficionado, but for give a perspective, these are the best hands you can have in poker, royal flush being the best one. And here are this is what the guy had, a full house. And here are the probabilities of getting a full house, 1 in 694. Now, royal flush, you can see, is extremely uncommon, but yet this was alarming enough for him to admit himself to the hospital. Now, what's beautiful about this case is the physiology behind it. So this person was admitted to the hospital for 3 weeks. These are the era before, I suppose, Medicare and Medicaid and social case managers pushing people to get discharged from the hospital. And he was put on a low-calorie diet. And over the period of time, he lost a significant amount of weight. His BMI went from 44 to 38, and he had resolution of his symptoms. But look what happened to his pulmonary function test. His expiratory reserve volume went up, dead space went down, tidal volume went up, alveolar ventilation correspondingly went up. Oxygen consumption went down because, the more mass you have, the more oxygen you consume and the more CO2 you produce. CO2 went down, and they did hypercapnic ventilatory drive where they make the person breathe CO2 to see how much your ventilation goes up. And you can see that sensitivity to CO2 increased significantly. So this is a beautiful case from the 1950s showing what can happen with weight loss. Now, for the clinical practice guidelines, one of my former fellows, Max, who's now an associate professor at MSU, helped us do the analysis of impact of weight loss. And surprisingly, there wasn't that much literature when we did the guidelines to make reasonable inferences. But from what we could gather was around 25 to 30% weight loss that would needed to be achieved to get resolution of hypercapnia. That's what we did our best to make some inferences, and that's what we came up with. And I want to share with you this slide from China that was just recently published in the Journal of Clinical Sleep Medicine. So this was a retrospective study, where they looked at more than 1,000 patients who were being admitted to the hospital electively for bariatric surgery. And in China, the medical system is a little bit different. They can get admitted to the hospital for pre-op workup for many, many days, as opposed to the United States, where the length of stay is much more rigorously controlled. Anyway, of these 1,000 patients, 187 had evidence of OHS. That was 16% of their cohort. And these were patients who were diagnosed with OHS on that hospital elective admission. They were not known to have OHS or OSA. So they had 151 patients who had follow-up at 1 year after bariatric surgery. Interestingly, the majority of their patients were men, and they were quite young cohort. And this is the type of surgeries they underwent. And none of these patients were previously diagnosed with OHS or on PAP therapy for that matter. And the duration of PAP therapy was only during the hospitalization. Before that, they were not on PAP. So the average duration of PAP therapy before surgery was only 6 days on average. And here you can see what happens at 1 year with these patients. The BMI, you can see OHS is more common with lower BMIs in that population, as I said earlier, but significant weight loss, as you can see. PCO2s, these, again, milder forms of hypercapnia, but still they got better. The AHI went down with the weight loss. But look at the hemoglobin A1C and the blood pressures, significant improvements. And these are the things that CPAP or non-invasive ventilation cannot achieve. So weight loss should be very, very important stay of intervention for these patients. Now, they defined OHS resolution as no evidence of hypercapnia on an arterial blood gas after 6 months of being off PAP therapy. And you can see that close to 70% of the patients had resolution of hypercapnia. So on average, these patients spend 10 days in the hospital, 6 days pre-op, 3 days post-op. So in the United States, you cannot have people stay for bariatric surgery in the hospital for 10 days. It never happens. But anyway, in general, they didn't have increased rate of intubations or any deaths. And the ICU admissions that they had were essentially elective admissions. So my point is, surgery can be done safely in these patients. Now, this is an interesting paper that was published recently from the Swedish National Registry for Home Mechanical Ventilation, or NIV, home NIV. And this cohort is essentially looking at all cases of NIV. Oh, and now I am highlighting here 36% of the cases was OHS in Sweden, requiring, in this registry, national registry of people getting home NIV. And OHS was the most common reason in Sweden to be on home NIV. And what they were looking at is whether hypercapnia gets controlled or not, and how that correlates with outcome. And here you can look at the survival curve. On the x-axis, you have years on long-term mechanical ventilation at home or home NIV and probability of survival. Now, if the patients achieved at around 1 year a PCO2 that went below 45, meaning they were able to normalize their CO2 compared to those who didn't, they had better survival. So the goal of achieving eucapnia or normalizing hypoventilation is an important goal, in my opinion, to have. And again, these are all comers. This includes COPD, neuromuscular disease, but the majority of the patients were OHS. And the goal of achieving eucapnia was more commonly achieved in patients with OHS. 67% of them achieved eucapnia. Of course, we all got very excited or are excited about the role of tirzepatide in obstructive sleep apnea. And you can see that some of these patients can lose close to 20% or 18, 19% of their body weight. But again, I think as a field, my hope is that we push these companies to sponsor clinical trials in OHS and not just take it as a leap of faith and say, okay, well, this will also apply to OHS. Hopefully that will happen. We'll see. So let me conclude by saying that hopefully I've convinced you that OHS is probably more prevalent than what you thought it is, but it's frequently unrecognized and undertreated, which can worsen patients' outcome. Pulmonary hypertension is particularly common in these patients, and I think it can get better with adequate therapy, and I think that's important to think about. Now, in my opinion, the management of these patients should not be focused on just PAP therapy, because at the end of the day, weight management is a very important area that needs to be taken into account. And if you look at the data I showed you from the Pickwick trial, the most common reason for mortality in these patients were cardiovascular mortality, and PAP therapy may not have a major impact on that, but weight loss could. So I think that's important to think about, and it will be exciting to see if in the future we can come up with pharmacotherapy that can help augment ventilation in these patients, like the ones I talked about earlier, orexin agonist, or combination of acetazolamide with other upper airway dilators potentially. So with that, I'll stop and I'm happy to take any questions. Thank you.
Thank you so much again, Dr. Mokhlesi, for this amazing talk. Really appreciate again you coming and giving this talk and all your work in advancing this field. And if anyone has any questions, please type it in the chat room. I have one question here from Stuart Mann. What role does positional sleeping semi-upright play in improving OHS? In an OHS, how much does the daytime oxygen saturation change sitting versus lying flat?
No, that's a good question. I think I don't know how much literature we have on OHS in that regard, but in OSA, there's some growing literature about that. And I think the impact of positional therapy on upper airway collapse, upright, head of the bed elevation in OSA at least, is somewhat mixed. Some patients get significant benefit from that. In some patients, there's actually resolution of upper airway collapse and OSA with head of the bed elevated at 30 degrees, for example. And in some patients, there's not a major impact. So there's a lot of variability, from patient to patient. With that said, I think in these patients who are extremely obese, raising the head of the bed reduces the work of breathing, can reduce atelectasis at the bases. It reduces what we call intrinsic PEEP. And that by itself can lead to significant improvement. So I think there is a role in there. I don't think it will be enough or sufficient to replace PAP therapy, but I think it can significantly help.
I have a question. So, given all the benefits on pulmonary hypertension and cardiovascular risk with in OHS with the treatment, how should it guide our clinical practice? And also, with this combination, the Pickwick paper, do you think that could help Medicare insurance policy, change to access to NIV and OHS better like the COPD?
Yeah, that's a good point. As we were talking about earlier, I'm a little skeptical about whether Medicare is going to be willing to change access to non-invasive ventilation at a national coverage determination level for hypoventilation syndromes. As you all know, many times what we're forced to do in the United States is when you have a patient hospitalized and it's time for discharge, you know, since you don't fulfill all the criteria for a respiratory assist device, we end up prescribing, a home mechanical ventilator, which are of course very expensive. And I think there's two problems, and the government is coming after DME companies for doing that. The argument being that you're pushing clinicians to order home mechanical ventilators because it's beneficial to you in terms of financial benefit. I think whether that's true or not, I don't know. I mean, the government sued Apria, and Apria settled the case with them. I don't think physicians or clinicians order home mechanical ventilators for these patients because they're trying to milk the system. We're trying to do the best we can for our patients. I think our goal was to convince Center for Medicare and Medicaid Services to adjust their rules so the clinicians can prescribe in these hospitalized patients home NIV devices without having to jump on a ventilator, which is much more expensive. So we were making a financial argument, if anything. Yet they still didn't buy the argument yet. So we'll see. With COPD, they accepted, but for hypoventilation syndromes, they haven't. So I think the jury is still out on that. We're still pushing, but I don't know how much success we'll have, to be honest with you.
I know it's
One thing,
so
I'll tell you this. One thing that I think is a little nefarious when it comes from manufacturers of these devices is that when you look in Australia, in Europe, and in Canada, their AVAPs and IVAPs devices have the auto EPAP feature.
Right.
As you know, in the United States, if you want to order that, you have to go to a home mechanical ventilator device. And we've been pushing these manufacturers, ResMed, Philips, why is that? If that is approved in other countries, is adding your auto EPAP algorithm that you have in your CPAP devices to the AVAPs or IVAPs algorithm, and it will easily get FDA approved. So I've always been pushing them that, we get a little skeptical of why you're doing that. Are you trying to also milk the system so that more people order ventilators? We'll see. Hopefully at some point they'll add that algorithm so we'll be the same as Europe, Australia, and Canada.
Yeah. Or change all the criteria that we have for OHS, which is the most difficult one. I have a question here by Osima. How does your lab correct for CO2 drift on the TCM, the transcutaneous monitor? And do you have any protocols to switch from CPAP to bilevel just based on the transcutaneous monitors?
So the drift is a problem. I think the technology has gotten better over the years, and we're seeing less of it. Yet it's still a problem. The other thing is that sometimes I've heard clinicians saying, "Oh, I notice I put the CPAP or bilevel on, and I'm doing adequate titration, yet I don't see that much of an impact on the transcutaneous CO2." And I think the point here is that you won't see that. It takes time because there's a lot of CO2 in the body, as I was showing earlier, 120 liters of CO2, which is around 240 grams of CO2 in the body. So it's hard to get rid of it that quickly, and it takes time to get rid of it. So I wouldn't necessarily say that if your CO2 doesn't go down as dramatically as you were hoping to, it doesn't mean that your NIV has failed, because down the road they will get better. But the drift, unfortunately, there's no good way to do it other than reapplying the electrode, which is problematic because you're waking the patient up. It takes time to calibrate and is a pain. But it's one of the limitations of the technology we have, of course. It's a limiting factor. And in terms of when to switch to NIV, we usually tell our techs that if patient has persistent hypoxemia, and sometimes you see this, you put them on CPAP, they have severe OSA, the OSA is gone. The stimuli that they had for arousals, which was effort, goes away. So now they can actually go into REM. And you sometimes see this, they go into this profound REM and they have this profound hypoxemia to the point that they start having some arrhythmias. And I tell the techs, well, wake them up, get them out of REM. That's the easiest way to solve the problem. Snap them out of REM. And in subsequent REMs, they get better. That first REM tends to be sometimes problematic in these patients. In terms of switching them to NIV, our goal has always been resolve upper airway obstruction, all of the stuff that goes with CPAP. And if they still are hypoxemic, crank up the CPAP a little bit more, hoping that maybe the expiratory reserve volume and atelectasis will get a little bit better. And if despite that, they're significantly hypercapnic, assuming you have transcutaneous CO2 monitoring, then you can do a trial of NIV. But just because they try NIV doesn't mean I have to prescribe NIV. I may, at the end of the day, just prescribe CPAP and do a close follow-up of the patient in the outpatient setting.
Thank you. The other question from Brandon Noakes, do you think improvement in hypercapnia with weight loss are due in part due to reduction of the CO2 slow compartments, fat bone, etc., in addition to improving the drive and decreasing the overall carbon dioxide production?
I think it's a combination. For example, in that case from 1956, the guy who lost his poker hand, you notice that CO2 production went down because oxygen consumption went down. When oxygen consumption goes down, that means CO2 production goes down because you consume oxygen to produce CO2. So VCO2 went down. And you notice that hypercapnic ventilatory drive improved as well. So I think it's a combination of things. Which one goes first versus second, I'm not sure. But what I can tell you is that when you put people on CPAP or NIV without any major changes in their BMI or weight, over time, their hypercapnia goes away during wakefulness. And when you do hypercapnic ventilatory drive on these patients, they get closer to normal despite having the same weight. So I think in many patients is driven by the obstructive sleep apnea component of their disease, that with resolution of OSA with CPAP, they can normalize their CO2 in a few weeks if they're adherent to therapy without any change in BMI. And in some other patients where OSA is not the main contributor, and it's just, reduction in ventilation or obesity driven, weight loss can help them significantly. But it's probably a combination.
Thank you. That was great. And I guess what I was also getting at is how important do you think tissue level CO2 kinetics are? So Gattinoni had that Blue Journal paper where he talked about, sort of slow mobilizing tissue stores like bone and fat versus, the blood in the lungs, et cetera. And do you think that's important, or do you think that's just sort of an interesting observation?
Well, I think it's an interesting observation in terms of its clinical impact. I think the clinical impact of it would be to say that don't get frustrated if your CO2 doesn't necessarily normalize during titration. Even if it goes down from, say, 55 to 51 or 50, down the road, it will continue getting better, as you said, because the other CO2s in other tissues, slowly get released. And as the ventilation gets better, it takes time to eliminate all those CO2s that is accumulated in all the other tissues. It takes time. It's just not feasible for it to be done so fast.
Thank you. Another question is from Parvati, saying, for pulmonary hypertension patients with OHS, do you limit the max IPAP to a certain pressure when managing NIV, given their history of pulmonary hypertension?
It's a good question because, if you're preload dependent because of pulmonary hypertension, it could be problematic giving very high pressures. what we do notice, at least, well, in the Pickwick, the pressures were not extremely high. Now, that's not to say that people with OHS who get hospitalized cannot have, severe core pulmonality and have very high pressures. But in general, this is, I think, is a different beast if you think about it compared to pulmonary arterial hypertension, where patients are generally not severely obese. If anything, they're like normal weight, and they have severe RV dysfunction. I think in that patient population, you have to be much more cautious, and we're all cautious in the intensive care unit when these patients get, have to get intubated, for example. We all get very concerned about acute cardiovascular collapse. But in OHS patients who have a lot of obesity and also have a component of LV dysfunction that contributes to their pH, I think in general, they tend to tolerate reasonable pressures like 20, 21 of IPAP without any problems.
Great. Thank you. And then last comment question by Asima. Hopefully we can extrapolate the COPD national coverage, coverage determination to obese COPD and use it as well.
From your mouth to CMS ears. I hope so. Yeah, it's a tough, the CMS is a tough group. And I learned a lot of this, when this effort was led by Peter Gay and Bob Owens. Kristen Wan was also working with us. And when Peter told me that, it actually takes an act of Congress, I thought it was like, using it as hyperbole. But no, he said, no, it actually takes an act of Congress to change national coverage determination. They have to vote. I thought he was joking. So for Congress to change something, God help us. I don't think it's going to happen. So I'm skeptical at best. Let's put it that way.
We can be
I've become
hopeful
a pessimist.
All right. I don't see any more questions. If anyone has any last minute question, it's already 3. Feel free to ask yourself. Otherwise, well, thank you so much again. It was a pleasure having you here. There's Christine saying, so great to see you. Thanks for the wonderful talk. Thank you everyone for joining, and
My
we'll see
pleasure.
you next
Thank you.
week. Thank you so much again, Dr. Mokhlesi. Bye-bye.
My pleasure.